program manager at OHSU. I'm going to be talking about headaches. I did narrow my topic down a little bit. Headaches is a very big, broad topic. So I am going to talk more about headaches with a risk of stroke or associated with stroke. I'm going to talk about some primary and secondary headache diagnoses. And here are my objectives. I'll start with the primary headache diagnosis. We'll talk about migraine with aura and migraine without aura. And then a couple of the secondary headache disorders that I'll talk about are the cerebral venous thrombosis, cervical arterial dissection, and reversible cerebral vasoconstriction syndrome. We'll start with the primary. So first, migraine. So there are two primary types of migraine. We have migraine without aura and migraine with aura. And migraine without aura is characterized by a unilateral pulsating headache of moderate to severe intensity. Attacks typically last between 4 and 72 hours and are aggravated by routine physical activity. Often they're associated with nausea, as well as photophobia and phonophobia. A single attack can be difficult to fully define. So the International Classification of Headache Disorders does require a total of 5 attacks prior to the diagnosis to further characterize those headaches. There may also be prodromal syndromes present hours, days prior to the migraine onset. And these symptoms can include fatigue, neck stiffness, sensitivity to light, blurred vision. For our migraine with aura, these occur in about 20 to 30% of the migraine population and include the onset of fully reversible aura symptoms, typically followed by headache. And aura symptoms can be visual, sensory, speech, and speech would encompass dysarthria, which is not always considered a unilateral symptom, and can also include language, which would be aphasia. Aphasia is considered a unilateral symptom, which is important for the diagnostic criteria. Motor symptoms may be included or brainstem or retinal symptoms. So at least 3 of the following criteria must be met. Symptoms lasting between 5 and 16 minutes. 2 or more occurring in succession. Gradual onset over at least 5 minutes. And at least 1 positive symptom followed by a headache within 60 minutes of aura. So typically aura occurs before the onset of headache, but may also begin after the headache phase has commenced or continue into the actual headache phase. The headache that is present in migraine aura may not necessarily meet all the criteria as in migraine without aura, but due to the relationship with the aura symptoms, it can still be diagnosed. When looking at the most common symptoms associated with aura, visual aura is the most common and occurs in 90% of patients. Sensory symptoms are the next most commonly reported aura symptom and can be described as pins and needles, which start in one position and move over to one side of the body, either a larger or smaller part of the body, and may progress to what patients describe as numbness, or the only sensory symptom may be numbness. When multiple aura symptoms are present, they often do follow the same pattern of onset. And most often they persist for up to 1 hour, with motor symptoms tending to persist for a longer period. So under migraine with aura, we also have retinal migraines, and right here is the diagnostic criteria from the International Classification of Headache Disorders. I won't read through them just for the sake of time, but visual symptoms may be positive or negative. And this is also from the International Headache Society, and this is a representation of the array of visual aura that may be present. Migraine with brainstem aura. Again, here's the diagnostic criteria for that type of migraine. The guidelines, and I won't read through all the specifics. And then we have hemiplegic migraines with the diagnostic criteria. I want to highlight a couple of things here. First, motor symptoms generally last for 72 hours, but can often persist out to weeks. This is one of our stroke mimics because they do present with hemiplegia associated with headache. However, the prevalence has been reported at 0.01% in the population, so it is not a common diagnosis or reason for hemiplegia with headache, so that should be considered when patients do present. And most often, these do occur in children ages 12 to 17. And after this period, often those people with hemiplegic migraine do age out and present with more typical aura symptoms. So looking at migraine and ischemic stroke risk, there's a strong association between ischemic stroke and those with migraine with aura. And in a meta-analysis of over 2 million participants from 11 prospective cohort studies, the observed pooled relative risk of ischemic stroke in the migraine with aura population was 2.1%, compared to the control, which was the population without migraine. And in this particular meta-analysis, there was no association with risk of ischemic stroke in the population of those with migraine without aura. So some of the additional risk factors for ischemic stroke in the population of the population with migraine include women, so particularly less than 45 years of age, use of oral contraceptives, especially those containing estrogen, and smoking. And there's a stronger association with the risk for ischemic stroke with those in with migraine with aura, and those with oral contraceptive use and other vascular risk factors, and particularly smoking with oral contraceptive use. Migraine with aura does not seem to be a risk marker for the older population, except in those who are older and currently smoking, or those with migraine with aura onset later in life. The risk for ischemic stroke in migraine with aura is greater in those with active aura, so occurring within the past 12 months, and those with a high frequency of occurrence. However, there's no definitive evidence that the severity of the migraine influences that risk for ischemic stroke. And there's no evidence to support prophylactic migraine treatment reduces the risk of ischemic stroke. So reducing the frequency of migraine doesn't actually reduce the risk for ischemic stroke in that population. And this really emphasizes the need to address other vascular risk factors associated with stroke in this population because of the elevated risk. There's also an increased risk of ischemic stroke in patients undergoing surgical procedures performed under general anesthesia. And that has been appreciated in those with migraine versus those without. But the association between migraine and perioperative stroke risk was greatest in those with migraine with aura versus those without. And there have been several observational studies as well, which demonstrate those with migraine with aura have a higher prevalence of PFO, and that migraine is more prevalent in those with PFO. And there was a series done at a comprehensive stroke center at the University of California, which showed 93% of patients with cryptogenic stroke and migraine with aura had a PFO. And it's uncertain if the relationship between these two are causal or coexistence. Therefore, the decision to close a PFO should not rely on migraine status alone. And in addition, there's no evidence to support primary stroke prevention in those patients with PFO and migraine. So some of the diagnostics, while new imaging techniques are becoming more available, they are typically not part of the routine diagnosis in people with migraine. Guidelines from the American College of Radiology and the American Headache Society recommend patients with migraine and normal neurologic exam do not have routine neuroimaging. However, there are a few instances in which imaging might be indicated. So MRI would typically be indicated for those with atypical headache, a recent change in headache pattern, or other symptoms such as seizure or focal neurological deficits. And then I have here this acronym that was created just to help remember some of those red flag reasons for additional imaging in patients with migraine. It's the SNOOP-4. That there. And depending on the concern, CT or MRI might be the preferred imaging modality for these patients. So for preventative treatment, these are the agents that we typically use at our institution. The International Headache Society does have recommendations for a further list, but we typically go to beta blockers, antidepressants, and anti-epileptics. The topiramate is our preference there. All of these are safe to use in stroke patients as well. So looking more at the abortive treatment, these are recommendations per the American Headache Society. And a few of the considerations for abortive treatments in the stroke patient population, the recommendation is to avoid triptans and DHE. This is primarily related to the mechanism of action of triptans. There's no clinical trial evidence to support this recommendation, but because of how it acts, the recommendation is to avoid in those with stroke, cardiovascular disease, or hypertension. The recommendation would be to consider the GPANs or the serotonin 1F receptor agonists. And these are because they're not, they don't have any vascular, they don't act on the vascular system. So I'll move on to secondary headaches. So CVT, this is the diagnostic criteria from the International Classification of Headache Diagnosis. So CVT includes thrombus formation in the dural sinuses or in the cerebral veins or both. Above, you can see the representation of sinus involvement and the frequency of involvement in CVT presentation. The transverse sinus and the superior sagittal sinus are often involved. You can see they have the highest prevalence, highest frequency there. And often more than one is involved. So less than 0.5 to 1% of strokes are the result of thrombosis of the cerebral veins or the venous sinus. And some of the presenting symptoms are related to intracranial pressure or focal parenchymal injury with or without mass effect. So headaches are present in approximately 90% of patients with CVT and is the most prevalent symptom. Some of the key clinical features of the headache may include headache that's exacerbated by Valsalva, laying flat, or more subacute onset of headache and headache that is more diffuse in nature. However, acute headache with migraine-like qualities can also be present in this patient population. Up to 1/3 of patients may present with an isolated headache and no additional symptoms associated with increase in intracranial pressure. So most are presenting with some symptoms of that increase in intracranial pressure. And the symptoms associated with increase in intracranial pressure would include nausea, transient vision loss, papilledema, and diplopia, in addition to some of the other cranial neuropathies. Seizures may also be present and are present in 20 to 40% of patients. And a wide range, but 20 to 50% of patients do present with focal neurologic deficits. And these deficits tend to have a more progressive onset compared to those presenting with arterial stroke, which tend to be more maximal at onset. And a minority of patients do have a more acute onset. They may also have encephalopathy, and coma has also been reported in up to 20% of cases. So some of the associated symptoms, CVT occurs more frequently in the young. And here is a list of some of the associated conditions, which may be either transient or chronic in nature. CVT is associated with hormone use in pregnancy, likely contributing to the increased occurrence in females, particularly females of childbearing age, and is associated with other comorbid conditions such as head and neck infection or obesity, some medications, and malignancy, as well as autoimmune disorders, genetic thrombophilias, or maybe mechanical in nature. They may also be found to have compressive lesions, such as a meningioma, which is impeding on one of the venous sinuses. So in 80% of patients with CVT, at least one factor is identified, and almost half of the patients, more than one factor is identified. There's also been an increasing incidence of CVT over time, and this may be related either to increased availability of neuroimaging, which would increase recognition, or increase exposure to predisposing factors. So for diagnostics, typically a head CT or MRI are the first images obtained in patients presenting with headache or nonspecific acute symptoms. There may be evidence on initial imaging suggestive of CVT, like direct visualization of the thrombus, which you can see in panels C and D. just would exercise some caution and interpretation of that initial imaging because the transverse sinus may appear atretic, but not necessarily be representative of CVT. Hemorrhage can also be seen on CT and is present in approximately 1/3 of patients. And there should be increased suspicion when you are seeing hemorrhagic venous infarcts in multiple interparenchymal or multiple areas. Overall, you can see MRI with conventional sequences do have a higher sensitivity and specificity for CVT, but advanced imaging is generally required to diagnose or rule out CVT. And so MRI and MRV are the primary recommended non-invasive studies to confirm the diagnosis. CVT may be a reasonable alternative as well. So management, anticoagulation is the first line treatment in CVT, and this is even in the presence of venous hemorrhage. So venous hemorrhage is not a contraindication for anticoagulation. The objectives of anticoagulation therapy are to prevent thrombus growth, facilitate recanalization, and prevent recurrent events. And currently, the American Heart Association and the European guidelines for the management of CVT do recommend heparin, followed by a transition to vitamin K antagonists. The guidelines do have a slight preference for the use of low molecular weight heparin, and this is because of a trend towards improved functional outcomes and mortality with the low molecular weight heparin, but there was no difference in the rate of bleeding. And the timing of transition from heparin to oral anticoagulation is uncertain, but it's reasonable after an initial lead-in period. And in a recent systematic review comparing DOACs with vitamin K antagonists, there were similar rates of recurrent VTE, major hemorrhage, and complete recanalization. So we tend to use the DOACs instead of the vitamin K antagonists. And the duration of therapy is typically 3 to 12 months with transient risk factors. The AHA, ASA guidelines recommend 3 to 6 months. Duration of anticoagulation is reasonable in patients with a provoked CVT. And those with an unprovoked CVT, it may be reasonable to continue for 6 to 12 months. So indefinite anticoagulation would be considered in those with the presence of a thrombophilia or recurrent VTE. So when considering the duration of anticoagulation and making decisions, the degree of venous recanalization remains an area of uncertainty to make those decisions about duration. In addition, endovascular therapies, including mechanical thrombectomy with or without thrombolysis, is reserved for those with evidence of thrombus propagation or those with neurologic deterioration despite medical therapy, and those with other contraindications to anticoagulation. And there's no evidence to support one endovascular technique over another. Lastly, refer to ophthalmology for visual field assessment, especially those with risk of developing increased intracranial pressure, and shared decision-making regarding Topamax and acetazolamide. The acetazolamide may also be used to help reduce headache associated with CVT. So moving on to cervical artery dissections. This is, again, the diagnostic criteria. Oh, and I will say here at the end, headache has resolved within 3 months. 3 months, it marks the time from stabilization rather than the onset of dissection. So cervical artery dissection is a cause of ischemic stroke in young patients in about 15 to 24% of cases. The overall incidence of cervical artery dissection in the general population is low and estimated to be around 2.6 to 3.0 per 100,000 people. Internal carotid artery dissections are more common than the vertebral artery dissections. Some of the presenting symptoms, ischemic stroke or TIA may be the initial presenting symptom in cervical artery dissection. However, local symptoms typically precede the ischemic event in a majority, up to 82% of patients. And typically occur within the first week after local symptom onset. So headache and neck pain are the most common presenting symptoms in cervical artery dissection. Headache occurs in 60 to 90% of cases, and it's typically unilateral and associated with ipsilateral face and neck pain. In addition, you may see an ipsilateral Horner's syndrome, and this is just related to the distension of the sympathetic fibers that expand the external surface of the carotid artery. You also may see some cranial nerve palsies, particularly a 9, 10, or 12. And pulsatile tinnitus may be present as well. And in vertebral artery dissections, headache is seen as a presenting symptom in up to 70% of cases. Typically occurs in the occipital region, and often these patients will have cervical neck pain as well. So some of the risk factors for cervical artery dissection include connective tissue disorders, particularly fibromuscular dysplasia, and fibromuscular dysplasia is present in about 40% of cervical artery dissection cases. There's a smaller proportion of patients that present with other monogenetic connective tissue disorders. And then looking at some of the environmental factors that may be associated with cervical artery dissection, it's usually minor cervical trauma. So cervical manipulation therapy, like chiropractic neck manipulation, severe coughing or sneezing, contact sports, yoga, weightlifting, and then some of the predisposing factors would include pregnancy, oral contraceptive use, migraine history, or recent infection. There's also a theory around the presence of these genetic factors in combination with the environmental or minor trauma contributing to dissection. In terms of diagnostics, those patients with presenting with headache and suspicion of headache secondary to cervical artery dissection, the guidelines do require that the cervical artery dissection is diagnosed. So CTA or CT, CTA, and MRI, MRA are the most commonly used. And carotid artery dissections most commonly occur 2 to 3 centimeters distal to the carotid bifurcation, and vertebral artery dissections are most commonly seen in the V2, V3 segments. They have MRA, MRI, and CTA, CTA both have good sensitivity and specificity for diagnosing dissections. CTA is a little bit better for the vertebral artery dissection diagnosis. And because of the association with fibromuscular dysplasia, there are some additional recommendations around diagnostics for the evaluation of cervical artery dissection. In terms of management, the initial management is typically in regards to managing the ischemic stroke that might occur as a result of the dissection. Although the guidelines, the HA and the European Stroke Association or Stroke Organization guidelines do make reference that it is reasonable to give thrombolytics in this patient population. However, thrombectomy is not common in this patient population. And because a majority of ischemic strokes occur because of artery-to-artery embolism, early antithrombotic therapy is critical to reduce that risk of ischemic stroke. There has been some conflicting data around the effectiveness and safety of either anticoagulation or antiplatelet therapy for these patients. And so either is acceptable. And the duration of antithrombotic therapy is usually the AHA and ASA guidelines do recommend between 3 and 6 months. Decisions to extend the thrombolytic therapy past the 6-month mark may be considered in the context of the individual's overall vascular risk factor profile, as well as with considerations of neuroimaging features regarding the remodeling that occurs in dissection healing. And so therefore, repeat neuroimaging is typically done at 3 to 6 months after dissection. In terms of headache management, there are no specific guidelines around headache management and cervical artery dissection. However, avoiding NSAIDs with anticoagulation use because of the elevated risk of bleeding. So our CVS, so this is a self-limiting condition attributed to transient cerebral vasospasm. Most often, patients will present with a thunderclap headache. Often these headaches are recurrent and occur within the 2 weeks leading up to presentation. Some of these patients do present, however, at the time of their initial thunderclap headache. The headache is present in 67 to 86.5% of patients presenting with RCVS. And characteristics associated with RCVS include explosive or pulsatile throbbing, but the location is variable and has not been found to be diagnostically beneficial in making this determination. Headaches typically last between 1 and 5 hours, and a duration of a headache lasting less than 1 hour was less common in our CVS patients as compared to other patients with other causes of thunderclap headache. So the pattern of recurrent thunderclap headaches, usually between 2 and 10 episodes in the 1 to 2 weeks, is very suggestive of our CVS. And headache may also be associated with or may precede ischemic or hemorrhagic stroke as well. Up to 43% of patients will also present with nausea and vomiting, focal neurologic deficits, or a seizure. And focal deficits are usually considered the consequence of associated complications of RCVS. So TIA, stroke, hemorrhage. And it can occur spontaneously in the absence of predisposing factors, but overall, the percentage of patients identified with an identifiable trigger was high, and there are some studies that suggest, in 55 or so % of patients. There are other studies that suggest identifiable triggers in up to 90% of patients. So while a number of triggers and precipitating factors may be identified, the most common identifiable precipitating factors are vasoactive drugs. Women in the postpartum period, and that was present in 31% of patients. RCVS has a mean age of onset between 40 and 50, and is, again, because of that postpartum contribution, more common in females. So some of the useful diagnostics. So identification of exposure to a known RCVS trigger is useful in the evaluation of thunderclap headache. There may also be radiographic evidence of vasospasm, and this vasospasm should, on imaging, be reversed at 3 months post-symptom onset, and this is required for a definitive diagnosis of RCVS. So imaging may be normal, and it is normal in 30 to 55% of cases, but you also may have evidence of vasoconstriction on CTA or MRA when the larger cerebral vessels are involved. Vessel imaging can demonstrate multifocal vasoconstriction. It'll often appear as a string of beads, and can also develop 2 to 3 weeks after the onset of symptoms. So it has delayed presence on, or it can have delayed presence on imaging, and then persists for a period of time. And it's not well known if the delayed appearance on imaging is related to us just not being able to see that versus it not being actually present. So there was one study that evaluated vasoconstriction and did identify that vasoconstriction appeared in different cerebral arteries at different time points, with peak vasoconstriction identified on around day 16 post-symptom onset. If CSF evaluation is done in the workup of a thunderclap headache, CSF would be normal in RCVS. So because of the difficulty in diagnosing RCVS in the acute period, there are a couple of tools that can be used. And one is, there's a definition for probable headache associated with RCVS given by the guidelines, as well as the RCVS2 scoring system, which helps to with that diagnostic suspicion, and that I have listed here. And when scores are above or equal to 5 on the scale, they can range from -2 to 10. It does have a 99% specificity for diagnosing RCVS, as well as a high sensitivity. So for management, management for RCVS is mainly based on observational studies, small case series, and expert opinion. So there's no great guidance around the management of RCVS. However, trigger factors should be eliminated if they can be identified. And consideration of using analgesics or calcium channel blockers for headache relief. In terms of headache, This is another area that triptans should be avoided because of the possible vasoconstriction and the pathophysiology of our CVS. For calcium channel blockers, you can consider nimodipine or verapamil in these patients. And there was a study that observed reoccurrence in our CVS patients in about 5 to 10% of cases. And headache may actually persist beyond the vasoconstriction time period. Often patients can experience headache out to a year post diagnosis, and also in about 26%, they do develop depression. So again, avoiding triptans, and in terms of depression management, looking at those non-pharmacologic interventions as like SSRIs can be associated with our CVS. My references.
Thank you very much.
Thank you.
Headache is indeed a complex subject. I listened more and got more headache.